After any destructive ophthalmic surgery, an orbital implant is inserted within the orbit and the patient wears an ocular prosthesis to restore an appropriate cosmetic look. The prosthesis may or may not be pegged to the implant and is typically fitted 6 to 8 weeks after surgery to allow healing of tissues and suture absorption. Implants may be spherical or have a specific shape. They may be pegged to the prosthesis for better motility, and they may be wrapped or unwrapped in various materials such as donor sclera, autologous tissues such as temporalis fascia, dermis, human donor pericardium, fascia lata, or posterior auricular muscle complex, or by synthetic materials. An orbital implant is placed after destructive surgeries to restore the missing orbital volume. In evisceration, the contents of the eyeball are removed, leaving the sclera and tenons capsule intact. In enucleation, the entire eyeball is removed after cutting the extraocular muscles and the optic nerve. Excentration involves the removal of all the contents of the orbit, including the periosteum and eyelids. Klufas et al. Even reported use of a custom implant brachytherapy following exenteration. Various materials are used for orbital implants. Autologous materials which have been used are dermal fat grafts, post-auricular skin graft for contracted socket, bone grafts with musculus temporalis flap, anterolateral thigh flaps, and periumbilical fat autograft. These are rarely used but may be indicated for economic considerations when other materials give rise to persistent pain or inflammation, for wrapping other implants, or to cover exposed implants. Polymeric grafts are still used extensively because they are inert and relatively inexpensive. Silicone implants are preferred by some surgeons in pediatric patients because of their ease of removal for the purpose of implant exchange. PMMA has high biocompatibility and, like silicone, may be preferable in pediatric patients for ease of removal. Among the more famous are the non-porous semi-integrated ones from the Allen family, which involve anchoring of the implant to the overlying prosthesis. The better developed ones of this family is the Iowa implant, which has 4 mounts that match corresponding depressions on the prosthetic surface for proper anchoring, and also 2 channels for suturing of the horizontal and vertical muscles. The universal implant is a modification of the Iowa implant, wherein the mounts are shorter and more rounded, thus reducing the incidence of tissue necrosis above the mounts. The Castroviejo implant is a variant of the Allen type implant and has 4 channels to house the extraocular muscles, which can be sutured by overlapping. The Sahaf type 1 was developed in Pakistan to enable an easily available implant at an affordable cost. The Sahaf type 2 is a pear-shaped implant wrapped in donor sclera or autogenous fascia lata and placed deep in the orbital apex on the orbital floor, and which projects up to fill the orbit and has been used in enucleation and exenteration. The Codier Duret graft can be used for anophthalmia as well as for repair of an orbital flow fracture. It has multiple tunnels for fibrovascular growth. Implants such as the Medpore that use polyethylene have a network of linked holes that permit tissue to grow in. Medpore is a low-cost alternative to ceramic porous implants, and when used nowadays is wrapped anteriorly for greater stability and left open posteriorly to permit fibrovascular ingrowth. Later versions of the Medpore implant include Medpore SST, which stands for Smooth Surface Tunnels, and Medpore Quad, which is conceptually similar to the universal implant. The early part of the 20th century saw glass implants, hence the term glass eye. In recent times, porous ceramic implants have become popular as they have an interconnected network of channels which facilitate host fibrovascular ingrowth, a condition that significantly improves prosthesis motility if combined with pegging, and which reduces the risk of migration and extrusion. Of these, hydroxyapatite is a commonly used one. It is often wrapped in donor sclera, autologous fascia, or synthetic mesh. Hydroxyapatite implants are probably the most studied of all the orbital implants and may be coralline, containing calcium phosphate salt that is present in marine coral and available commercially as BioEye sphere, synthetic, available commercially as FCI implant, or bovine hydroxyapatite, available commercially as Molteno M sphere. Aluminum oxide is another porous ceramic implant available commercially as bioceramic orbital implant. It is inert, biocompatible, has a smoother surface, and is cheaper than hydroxyapatite. Because of the necessity to replace these implants in growing children, they are suitable only for adults. Composite grafts are made of more than one material. The Guthov implant has a frontal fragment made of artificial porous hydroxyapatite for tissue incorporation and a subsequent silicone hemisphere. The muscles are stitched in front of the graft to obtain better stability and motility. It is, however, quite expensive. Medpo Plus, a mix of porous polyethylene and 45S5 bioglass particles, has been found to have good success. Magnetic implants were a creative technique to keep the prosthesis connected to the implant. The main drawbacks are metallic toxicity and subsequent tissue necrosis, and so these implants have not become very popular. Coming to the complications of orbital implants: inflammation with or without infection, implant exposure or extrusion due to breakdown of the covering layer and or conjunctiva. These two are the most common complications of all implants. Then ectropion, usually of the lower lid, formation of a dense avascular fibrous capsule surrounding the implant, enophthalmos due to inadequate volume replacement, ptosis, pyogenic granuloma, superior sulcus deformity is a deeply sunken area due to loss of orbital volume and inadequate volume replacement. If you like this video, you may show your appreciation by making a small contribution to help support the channel. Here below the video window, click on Super Thanks. Choose the amount you would like to contribute and then click Buy and Send to complete the transaction. Thank you.